He's a resident of Delhi, retired by occupation, is a known case of chronic kidney disease stage 5D on maintenance hemodialysis, came for routine hemodialysis. He was examined on 12th of February 2022. History given by self seems reliable. I would like to start my history from 2010 when he had holocranial headache. It was not associated with any loss of consciousness, seizures, or any focal neurological deficit. It was not associated with any blurring of vision. At that time, he was first time diagnosed with hypertension with systolic BP of 160 mm of Hg and diastolic BP of 90 mm of Hg. He was, however, non-compliant to his antihypertensive medications. He never took any medications because he did not feel any symptoms. On occasional BP checkup, he used to find his BP was always high in the range of 160 by 90 mm of Hg. He had no history of chest pain, palpitation, loss of consciousness, focal neurological deficit. He has no history of nocturia or decreased urine output. He has no history of any hematuria or frothing of urine. He did not do any blood or urine test at that time. In September 2013, he started having frequent episodes of nausea associated with vomiting. Vomiters used to contain food particles. It was not associated with any hematemesis. It was also associated with decreased appetite. Initially, he used to eat 4 to 5 chapatis during one meal, which then decreased to 2 to 3 chapatis at one meal. And these symptoms are present for last 2 to 3 months. He went to local private practitioner for these symptoms, and he was advised complete blood count and renal function test. And he remembers that his hemoglobin was 6 gram per DL and his creatinine was 6.5 milligram per deciliter. His BP was also high, around 170 by 90 mm of Hg. He was then admitted for his above complaints, and he was started on antihypertensive medication, symptomatic treatment, and his hemodialysis, his first hemodialysis was done through right internal jugular IJHD catheter. There was no history of any hematuria, frothing of urine, pyuria at that time. There was no history of any loss of consciousness, focal neurological deficit. On direct questioning, he said he had history of nocturia, and he used to get up 2 to 3 times at night for micturition. Initially, HD was done through right IJHD catheter. Left radiocephalic AV fistula was made, and later HD was continued through left radiocephalic AV fistula. He experienced one episode of catheter-related bloodstream infection during that time. It was managed with IV antibiotics and non-removal of HD catheter. There was no any hemodynamic or metastatic complications. HD was then continued through left radiocephalic AV fistula, initially twice per week, and then was shifted to twice per week for 2 weeks and thrice per week for 2 weeks, as his urine output declined from around 600 to 8 ml per day to less than 100 ml per day. His radiocephalic AV fistula was functional for around 2 years, and it stopped functioning after an episode of hypotension during dialysis. Left brachiocephalic AV fistula was then made, and dialysis was temporarily continued through right IJHD catheter till maturation of AVF. He experienced another episode of CRBSI during this time and was managed with IV antibiotics. Currently, he is on twice per week hemodialysis for 2 weeks and thrice per week hemodialysis for 2 weeks with a blood flow rate of 250 ml per minute. He is using a dialyzer of F6 HPS. His dry weight is around 60 kg with interdialytic weight gain around 1 kg on thrice per week hemodialysis and 2.5 to 3 kg on twice per week hemodialysis. He is having frequent episodes of interdialytic hypotension for last 5 to 6 months, which is managed conservatively. His antihypertensive medications are stopped in view of controlled blood pressure for last 5 to 6 months. He was initially on potassium-free hemodialysis for last 5 to 6 years, but later now he is on, and for which he used to get potassium-free hemodialysis, but now he is on regular maintenance hemodialysis with normal calemic dialysate solution. He is on injection Cres 40 microgram once every 2 weeks. There is no history of any chest pain, palpitation, shortness of breath during pre or post HD. There is no history of any bleeding episodes. There is no history of any pruritus, no history of burning sensation or symptoms, burning sensation over feet and palms. There is no history of body aches, fatigue, generalized weakness. There is no history of any muscle cramps during hemodialysis. Past history, so this was the current history, HOPA.
Total diagnosis of the patient, Gaurav?
The
CKD 5D, no doubt. Multiple has been
seen out. Sir, his past history, sir, he is known hypertensive for last 12 years, hypothyroidism since last 10 years. He
No,
had
what is his diagnosis? Don't go back into it. Otherwise, we'll spend all this time in this only. Hai na? We have to quickly get out of it and roll on to dialysis, right? That is the endeavor today.
yes, sir.
What do you say? So, at what age he got his azotemia, so to say, blood pressure?
At the
I think
age
around
of
50.
yes, sir.
So, what possibilities came to your mind at that time?
Sir, he was diagnosed hypertension. Like
Right.
he was diagnosed hypertension at the age of 50 years, and it
Mhm.
was he was non-compliant to his antihypertensive medications, and it
Yeah,
was
I remember all that. So, what do you think was the cause of that hypertension? Eventually, CKD हुआ ना, उसको dialysis
sir,
करना पड़ा.
sir,
What do you think is the diagnosis in hindsight? Whatever it is worth. And the
sir,
second question is, what is the importance of etiology of your diagnosis in a hemodialysis, chronic hemodialysis program? Do they have any sanctity, or is just for the sake of asking? You understand the question, but
yes, sir, yes, sir.
if you know the diagnosis, will it help you in planning your CAPD outcomes, prognosis, etc.? That is why I'm asking.
Yes, sir. My diagnosis is, sir, chronic kidney disease stage 5D on maintenance hemodialysis. Basic disease, sir. First differential, I would like to keep hypertensive nephrosclerosis. Second differential, sir, query CG, and secondary to, sir, IgA nephropathy or FSGS with the diagnosis of essential hypertension with hypothyroidism with anemia with intradialytic hypotension, sir.
Did you have any history of very high blood pressures recorded in that interim of 2 years? See, the
No, sir.
problem against hypertensive nephrosclerosis is, I think in 2 to 3 years' time, he went into ESRD, right?
Yes, sir. But sir, he was diagnosed in at the age of 50. Maybe he was not diagnosed before. He did not have symptoms, and that was the main reason he was not taking any medications, because he felt all right even after getting diagnosed, sir.
So that is not very uncommon. Most of our OPD patients refuse to take blood pressure medicines. They never take it. They feel that they'll become addicted to blood pressure medicines, right? They never take it.
Yes, sir.
What else would you think of? I would say this is like 3-year history of hypertension and led to ESRD. Can we say that? Yes, no.
Yeah, yes, sir. 3 years of detected hypertension, sir.
Hmm?
Yes, sir.
What else will you think?
Sir, underlying, sir, glomerular disease like IgA nephropathy or FSGS, because
हाँ तुमने बताया FSGS तुम्हें लगता है इसको था कोई प्रोटीन वो एडिमा
हिस्ट्री
नहीं
नहीं
कुछ
है.
नहीं
हाँ सर,
हाइपोएल्बुमिनीमिया नहीं FSGS 3 साल में malignant FSGS या कोलैप्सिंग हो तो सकता है बट लगता नहीं है ऐसा.
हिस्ट्री
अच्छा
नहीं
चलो
है.
supposing I say what etiologies if you make a diagnosis will help you in management of his hemodialysis down the ESRD line. क्या फायदा होगा? Can you give some examples?
Yes, sir. Like, sir, in diabetic or hypertensive patients, sir, ये patients they are prone for more anemia, high heart disease. So,
Diabetic are prone to more anemia or less anemia? Diabetic ESRD.
sir, more anemia, sir. They require more, say, hemoglobin.
No, I disagree with you. Anyway, let's go ahead. What else? Diabetes, yes. So diabetic अगर किसी को है तो और क्या problem है उसको dialysis पे?
Sir, associated, sir, autonomic dysfunctions, heart disease, sir,
अरे पहले
commonly
heart
associated.
disease बोलोगे यार.
हाँ, sir.
पहले heart disease बोलोगे. Autonomic dysfunction is also right. What percent of people have autonomic dysfunction in ESRD? Diabetic ESRD. What percentage of people do you think have autonomic dysfunction? Since you're talking about autonomic dysfunction.
I don't know the percentage, sir.
देख लेना. It's I think around 40%. 35 to 40%. और क्या प्रॉब्लम हो सकते हैं डायबिटिक ESRD को? हार्ट, yes, absolutely. Absolutely. सपोजिंग तुमने इसकी बायोप्सी की होती, अनुराग अभी पूछ लूं ना मैं इससे? अनुराग कहाँ भाग गया क्या? अनुराग? हाँ
जी सर, गो हेड.
हाँ, अगर सपोजिंग इसकी बायोप्सी की होती तुमने,
हाँ,
और बायोप्सी में तुम्हें नोडुलर ग्लोमेरुलर स्क्लेरोसिस मिलता, ठीक है, KW लीजन जो हम लोग पढ़ते थे, नोड्यूल मिलते, या मेसेंजियल एक्सपेंशन मिलता, नोड्यूल नहीं मिलते, कुछ फर्क पड़ता मैनेजमेंट में सब्सिक्वेंटली डाउन द लाइन?
Sir, in diabetes,
सवाल समझे कि नहीं बेटे? You have a right to ask if you don't understand.
sir, in diabetes patient or in this patient, sir?
नहीं, बायोप्सी करी तुमने, डायग्नोसिस नहीं पता थी, शॉर्टेज हिस्ट्री थी तुम्हारे
हाँ,
बॉस
sir.
ने, मेरे जैसा बॉस, सन की बॉस, उसने कहा बायोप्सी करो, बायोप्सी में KW लीजन आया, नोडुलर ग्लोमेरुलर स्क्लेरोसिस आई, तो
sir.
क्या आउटकम तुम सस्पेक्ट करते हो? सपोजिंग इसी पेशेंट में नोडुलर ग्लोमेरुलर स्क्लेरोसिस नहीं आती, मेसेंजियल एक्सपेंशन और मेसेंजियो ये सब डिस्ट्रक्शन आता, बट नो नोड्यूल्स, इन दोनों में से कौन सी सिचुएशन में आउटकम थोड़ी बेटर होती? सोचना है इसके बारे में.
So without,
ठीक है, चलो बताओ.
So without
If you know,
nodules,
I'm very happy.
because sir, retinopathy and neuropathy are commonly associated with those lesions. So it will matlab like
Which lesions? Which lesions? Which of the
KW
two lesions?
KW lesions. So if they are present,
Retinopathy is more common.
Yes, sir.
But outcomes किस में ज्यादा खराब होंगे?
Sir, KW lesions में sir.
KW lesion, and the other lesions will have more of hypertension. ठीक है? और क्या causes diabetes के अलावा जो तुम्हें etiology में help करेंगे डायलिसिस के मैनेजमेंट में?
सर जैसे ADPKD पेशेंट्स होते हैं तो सर उसमें more of connective tissue disorder, the fistula vascular access, the more we have more problem with the vascular access.
Like which disease you think will give you access problems?
Sir, ADPKD, diabetic
ADPKD
versus
gives you vascular problems, access problems.
They can affect the sir collagen structure because
vessel में what effect it will have on your radial and cephalic vein?
Not radial.
Brachial. What will it do there? Is there any documentation like that? At least I am not aware of that.
No, sir.
Chalo. ADPKD, if you're talking of ADPKD, it is very important. They have a lot of cardiac morbidities. If you transplant them, you have to be very careful. They have very silent cardiac morbidities besides the ones we know, mitral regurgitation and all those things we know. In spite of that, they have poor hearts. ADPKD people especially have poor hearts for some reason. Chalo. So if you know the etiology, sometimes it helps in even in management of dialysis. Okay. So let's say if this patient had hypertension of 2 to 3 years, and then he had a bout of severe hypertension, like he came to you with 210, 130, people do come like that, right?
Yes, sir.
Would you think of something besides?
Yes, sir. Malignant hypertension, suddenly there's kidney dysfunction with such a high blood pressure. First time it is diagnosed, so we have to rule out some malignant hypertension, sir.
What do you find in malignant hypertension in biopsy?
Sir, in biopsy, sir, we'll see fibrinoid necrosis.
Karoge biopsy? Will you do a biopsy?
Sir,
I think you will avoid it.
Yes, sir. Clinically, and if it is suggestive of malignant hypertension and TMA, so we'll avoid it, sir. Biopsy.
TMA is very important. Actually, I was running to TMA. You have said the right thing. Because malignant hypertension, by adequate control of blood pressure, the renal functions will improve very often.
Yes, sir.
Sometimes not, but if he has a bad TMA, and which is not so commonly, people are aware of bad TMAs, they will never improve. Yes, quite right. Quite right. Chalo, go ahead. So you have ESRD now, and he's on dialysis since 2013.
Sir, since 2013, yes, sir.
Yes. Okay. What else?
And sir, so should I say the full diagnosis, sir, with the comorbidity?
Examination.
Examination.
You didn't tell me the examination.
So he is conscious, cooperative, well-oriented, time, place, and person. His height is 173 centimeter, weight is 60 kg, BMI is 20.76, pulse is 82 per minute, regular, normal character, no radiofemoral delay. BP in right arm supine position is 130 by 90 mm of Hg. BP in right lower limb is 140 by 92, and left lower limb is 142.
BP should be measured in supine position. Do you think that is the best way to measure blood pressure? What are the recommendations for measuring blood pressure in 2021?
Sir, standardized office BP measurement.
So, what is the position? See,
The
that is how the examiner will catch you, na yaar. Examiner
Yes,
will never come prepared that I am to talk about hemodialysis complications. He may or may not. On the way, whatever he wishes, unfortunately, Examiner has the right to question you along the way.
Yes, sir. So back rest. In that
Supine. Nice
sitting
sitting position.
position.
Comfortably in sitting position. 20 minutes pehle, no caffeine, nothing, and 4-5 minutes of silence. Sitting is, we always took blood pressure in supine when we were postgraduates, but the recommendation is sitting position. Okay? Chalo.
Yes, sir. There was no
What else in
postural,
examination?
no postural drop. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, edema feed. JVP was not raised. Alopecia was present. Skin and nail changes were normal.
Alopecia was present.
Yes, sir. Yes, sir.
कैसा था alopecia? What type of alopecia?
Male baldness ही था sir.
तो उसको alopecia तो नहीं
नहीं,
कहेंगे.
हाँ, sorry.
Be careful with terminology. बच्चे
Yes.
you use. Be very careful. Go ahead.
AV fistula examination, sir. Radiocephalic, left radiocephalic AV fistula. The vertical scar was present over the 2 centimeter about the wrist joint. It was non-functional. No thrill was present. Left brachiocephalic AV fistula, sir. Inspection. Horizontal scar was present just above the elbow. Skin, there were no redness, discharge. There was a presence of pseudoaneurysm of size 2 to 4 centimeter. Skin above the aneurysm was not shiny. There was no edema of the hand or collaterals or ulcers at the fingertips. Palpations of thrill was present over the fistula. Arm elevation tests revealed no obstruction. Pulse augmentation also revealed no arterial obstruction. Auscultation thrill was present.
Chalo. When a fistula starts clotting, what are the first changes you expect in the palpation of the fistula?
Like thrill will, sir, it will be more hyperpulsatile fistula type. If the venous obstruction is there, so it will be more hyperpulsatile. If arterial obstruction is there, it will be like the pitch will be very low if it is arterial obstruction.
Pitch. How will you feel the pitch? Feel करोगे, auscultate करोगे?
Auscultate.
चलो, अच्छा. What else in examination?
Should
Anything else?
Positive. In cardiovascular, sir, so should I say only positive findings? Or
Depends upon what you call positive, maybe negative for me, and vice versa.
Sir,
फटाफट बताओ, time इसी में निकल जाएगा. We have 1 hour at our disposal.
It was present in 6th intercostal space, 2 centimeter lateral to the mid.
Never forget to mention apex beat, especially with old-time examiners like me. Because the presence of apex beat, which is outward, gives you clear-cut mandate that it is left ventricular hypertrophy straight away. So you must mention apex beat and thrill, parasternal thrill, lift if it is there, P2 is loud. Although these things are becoming less important now, but still they have some relevance. Okay. Any murmur, etc.?
No, sir. There's no murmur, but apex beat was out and down.
Okay. Any other posterior examination?
So fundus examination, it was hypertensive, grade 3 retinopathy, sir.
What is that classification?
Sir, Keith Wagner classification, sir.
Grade 3, what do you find in grade 3? Can you describe that for me?
Yes, sir. Sir, we find, sir, cotton wool spots.
Grade 3. अच्छा, what else? Fundus कौन examine करता है आजकल? बच्चे कहाँ करते हैं? Anyway, if you've done it, so what is grade 1, grade 2? Do you remember, or should we go ahead?
So grade 1 is, sir, like it was
देख लेना इसको ठीक से. इसको ठीक से देख लेना. Hypertension अगर बोल रहे हो ना, see, the problem is if you're speaking something, I don't expect you to remember Magdi, KW, classification, Keith, Wagner, Barker, but if you speak, then you give me the right to ask you. Okay, what else in examination?
This was the positive findings.
Abdomen, CNS, respiratory.
Yes. So CNS examination, sir. He is conscious, cooperative, well-oriented, time-based person.
Positive finding, any positive, important finding for her?
No, sir. No.
Did you see the ankle jerks?
Yes, sir.
They were present or absent?
Yes, sir. Present. They were present, sir.
They were present. Normally present or on Jandrasic maneuver?
So no, like I was talking to him and I did it, sir.
And they were elicited.
No, it was normal, which we see, sir, 1+ type to come with response.
Okay. Okay. So now your diagnosis is end-stage renal disease of dialysis duration of 8-9 years.
Yes, dialysis, sir, vintage of, sir, 8 years, sir.
Okay. So what is your total diagnosis which pertains to the dialysis complications and morbidities? I think that is what you want to highlight.
Yes, sir. So it is so chronic kidney disease stage 5D on maintenance hemodialysis with uh, frequent episodes of intradialytic hypotension with history of CRBSI with mild COVID recovered and with hypothyroidism with essential hypertension, sir.
Commonest causes of CRBSI that you have seen in your practice?
Sir, yes, a staph epidermis. Sir, we have seen, so both gram negative is also.
What has been more in your experience or in literature? Indian
Sir,
literature.
in literature, sir, they say coagulous negative staph aureus is common, but sir, we have seen both gram negative, like it is also, sir, more as or
Which
equivalent.
gram negative bug you see often?
Sir, Klebsiella and Pseudomonas, and sir, we have seen some slow growing like Ralstonia, the slow growing variety of Pseudomonas, sir, Ralstonium and Lytica types.
So, what measures would you take to prevent Class B?
Sir, exit care. Sir, we have to do a proper exit care. Then, while coming for dialysis,
Exit care.
So catheter exit care, sir. The tight dressing should be put on it, and sir, while
What else can you do? Are there any papers, any references you can give which can prevent or at least mitigate infection to some point? Patients with dialysis catheters.
Yes, sir. The KDOKI guidelines, sir. They were the recent ones which came, sir. KDOKI guidelines, sir. They mentioned, sir. So they mentioned about the catheter care, while the hair should be clipped, the patient should not take a bath, and then secondly, sir, it should be tight dressing should be done. Then they had told, sir, the KDOKI guidelines said we can apply, sir, triple ointment antibiotics over the exit site, or antiseptics can be applied, sir. And sir, while dialysis scrub the hub, they say, like, when we remove the hub of the catheter, we have to first we have to scrub it, then we have to keep it into the in the
any importance of antibiotic locks?
Antibiotics locks, sir, sir, for preservation of catheter in the presence of, sir, for preservation of catheter, we can apply antibiotic locks, sir.
Preservation of catheter? What do you mean by that? Preservation?
If you do not want to remove the catheter and there is tunnel infection, and if you want to preserve that access site, so we can apply, sir, catheter locks.
With?
With, sir, antibiotics plus anticoagulant. It contains, sir, we have gentamicin lock, sir. We have.
How much do you give in each?
Sir, the concentration is, sir, 10 milligram per ml. So we use, sir, 1 ml of gentamicin and 4 ml of heparin, and we combine it. We make a 5 ml solution, and we put 2.5 ml in both the, sir, catheter, arterial and venous. So 2.5
ml, do you think will not reach the bloodstream?
Sir, minimum, sir, all the catheters have the, sir, upper free space, which space 2.2 ml, 2.3 ml. So we insert that with the catheter, that with the antibiotic locks.
Okay. Okay, good. Go ahead. What else? What else your patients have faced?
Sir, he had, sir, persistent, sir, hyperkalemia for 5 to 6 years, for which he had to undergo potassium-free hemodialysis. And since last 3 years, sir, he is on normal dialysis. But in last 3 years, sir, his blood pressure is controlled, and his antihypertensive medications are stopped. And he's having some frequent episodes of intradialytic hypotension, sir.
So what are the causes of intradialytic hypotension? This I'm sure you will tell us very well.
Yes, sir. Intradialytic, sir, first the assessment of dry weight, sir. If the fluid removal is excess removal of ultrafiltrate causes intradialytic hypotension, sir. Secondly, sir, antihypertensive, like the pre-dialysis BP, if it is low, there are more chances of intradialytic hypotension. Associated, sir, cardiovascular disease, sir.
Like? Like,
Sir, dilated cardiomyopathy or sir, coronary artery
what
disease.
other cardiovascular disease? Have you seen any cardiovascular disease which gives rise to very severe hypotension in dialysis? And you should suspect it. At least in my life, I've seen 3-4 such patients, and we could bail them out.
Sir,
Hmm?
acute
अच्छा बता रहे हो यार, what is there to be nervous about? These are basic stuff. Pericardial effusion tamponade should never be forgotten. Never be forgotten. It could surreptitiously come in. See, what happens is patient comes late with pericarditis. We give heparin. You know, pericarditis is absolute contraindication to heparin, right?
Yes, sir.
But especially in COVID era, nowadays nobody auscultates patients just to see pericardial rub. So if you heparinize these patients in dialysis and they develop pericardial effusion, and surreptitiously this effusion keeps going on, and they may come with you with significant pericardial effusion with or without tamponade, and they may crash in dialysis. Never difficult to always remember that. What else? What else? Cardiovascular. What else?
Antihypertensive medications are taken on the day of dialysis.
Which medicines come out of dialysis? We do not.
Sir, ACE inhibitors are dialysable, sir. ARBs are not dialysable. CCBs are non-dialysable. Beta blockers, may sir, atenolol, metoprolol are dialysable. Carvedilol
To
are
a point. To a point.
yes, to a point, 50 up to 50%, sir. Carvedilol is sir not dialysable. Methyl dopa, sir, it is dialysable. It is also sir 50-60% dialysable,
Yeah.
whereas clonidine.
Have you used methyl dopa in your training?
No.
I doubt if it's available. Sir. It was a good drug, nevertheless. Achha. Okay, good. What other complications your patient faced? Tell me what are the other reasons of hypotension during dialysis? One is inadequate weight collection and wrong calculation.
Yes, sir.
Antihypertensive drug being there. What else could be the
dilated sodium?
We discovered cardiac causes. Yes, tell me.
So dilated sodium, like low dilated sodium can cause hypertension. Low dilated calcium can also cause hypertension, sir.
How will low dilated sodium cause hypotension?
Sir, diffusion, sir, like the sodium from the body will diffuse to the dilated compartment, and so the water will move and it will cause hypotension, sir.
If you do with low sodium bath, your plasma osmolality will fall because sodium will go out.
Yes, sir.
And as soon as the plasma osmolality falls, the intravascular water will go into the cells. It may come out or it may go into the set. So basically, the body will have very low intravascular volumes, right?
Yes, sir.
And that perhaps is the reason sometimes when patient has low blood pressures and you have to dialyze, how do you start that dialysis? 100 by 70 BP and your boss Anurag says, no, dialyze, give him dialysis.
We can do the sodium profiling in this
How
patient,
will you do
sir.
that? How do you do that?
Sir, we initially keep the sodium high, and later on we start decreasing the sodium. Sir, it can be done in the stepwise manner, or they say the linear manner.
Or very simplistically, what you can do is tricks. You can just do scuff initially. Just remove ultrafiltration, fluid. Don't give dialysis. Just remove fluid, scuff. Yes. And so that will not disturb the osmolality of the blood, and they will not get hypotension. And as the water starts coming out, the end diastolic volumes of the heart will be significantly benefited, and they may pick up. Okay. And beside that, sodium profiling. What else can you do to prevent hypotension during dialysis?
The same like sodium profiling, we can do UF profiling as well, sir.
What else?
Then we can increase the for maintenance. So we can the dialysate solution. The temperature can be lower. The temperature can be 0.5 degrees Celsius lower than the body temperature.
How will that help?
Sir, the cool dialysate will cause vasoconstriction, sir, of the blood vessels, and it will increase blood pressure. Then, sir, we can, sir, you should avoid eating during dialysis. Yes. You can do exercise. That will prevent interdialytic.
What are the causes of hypertension during dialysis?
Sir, excess weight gain, interdialytic weight gain is one of the commonest causes for interdialytic hypertension, sir. And sir, other causes can be the medication related, like EPO can cause a hypertension, or it can be, sir, So RAS activity, they say when the weight gain is too high, the RAS activity is persistently high even after removal of fluid, and it takes time to come to the normal. So it will cause persistence or hypertension, they say. And so dializable antihypertensives, if used, can cause high blood pressure.
Why do these patients have more chances of infections? Dialysis patient, forget the catheters, they are on a good AV fistula. What are the reasons of getting more infections?
Sir, chronic kidney disease, sir, per se is a immunosuppressed state, sir. So they are immunosuppressed, so that increases the risk of infection.
What are the causes of immunological dysfunction in these patients? 1, 2, 3, 4.
So because of persistent uremic state, this
क्या होगा
continues.
उससे? Uremia से क्या होगा? What will
Sir,
uremia do?
Inflammation, body can, sir, it will increase the body inflammation. It will cause endothelial dysfunction.
How?
So the
Urea
toxins
is a very inert substance.
Sir, apart from urea, there are other substances which do not measure. We do not measure in
Like,
which get accumulated.
Mention them.
Sir, all the toxins, sir, even PTH, sir, PTH, phosphorus.
No, mention the PTH. छोड़ दो. When you're talking of nitrogenous molecules, mention 4 or 5 compounds.
Urea, uric acid, creatinine, sir.
इंटरनल मेडिसिन वाली बात बता रहे हो. टॉक टू मी अबाउट नेफ्रोलॉजी फ्रॉम गंगाराम. मेरे को तो गंगाराम में घुसने में डर लगता है यार, इतना एलीट हॉस्पिटल है. यू आर एल्यूमिनाई ऑफ दैट प्रोडक्ट.
The gut related
is good one. Indole, guanidines, cresol,
phenols,
all that
amines.
stuff.
Yes, sir. Okay, sir.
So what are the reasons of immunological alteration in dialysis patients?
Sir, because of this toxin, sir, it will persistently cause inflammation in the body. It will cause cytokine stimulation.
They have abnormal T lymphocyte activation. Okay. And that triggers continuous IL-2 and activation and worsening of inflammation. You were right. They are inflamed. We all see dialysis patients are very inflamed. We call them PTW, protein energy malnutrition, protein energy wasting, PEW. And we used to call them inflammatory, what was it? We called cardiac atherosclerosis, inflammatory, MIA syndrome, malnutrition, inflammation. In my times, we used to say MIA very often, malnutrition, inflammation, atherosclerosis. So the causes of inflammation to my mind are abnormal T cell activation. It keeps on going on and on versus the inflammatory state. And you give whatever you want to give them, but the buggers don't improve. Okay. Okay. Tell me some causes of neurological complications in a dialysis patient.
The dialysis per se, sir, if done, sir, can cause disequilibrium syndrome. Dialysis disequilibrium syndrome per se, if we do not do a.
That is an acute complication, right? In your
Yes,
patient,
sir.
what do you expect now? 8 years down the line.
So dialysis neuropathy can occur, sir.
Dialysis neuropathy, ये term मैंने सुनी नहीं.
मतलब peripheral neuropathy, sir, secondary.
यार सुनो मेरी बात सुनो. You should use right terminologies, बच्चे. The minimum you should do is use the right terminologies. So what are the chronic neurological complications in a dialysis patient? Because your patient is already like a 10-year-old, 8-year-old dialysis progeny.
Sir, dementia, the cognitive dysfunction, sir.
There is dementia is one. Why does that happen?
Sir, because of the continuous osmotic loads and sir, toxins, they get accumulated. So the endoxyl crystals, they get accumulated in the brain, so it will increase the brain shrinkage and the so osmolality gets affected, sir.
What else? What
and aluminum was previously used, sir. Aluminum was previously used, so it can cause dementia, sir.
How would aluminum cause dementia?
So it gets deposited, sir, and it causes.
What were the other complications of aluminum?
Sir, anemia, bone
what type of anemia?
Sir, hemolytic.
that is all the listeners who are listening. That is how your Viva will go. I have not come with any preparation. He said aluminum, so now I want aluminum, right? What type of anemia you see?
So hemolytic anemia, alopecia,
microcytic hypochromic.
Microcytic.
Okay.
Yeah. Yes.
What else?
Alopecia, bone disorders.
What bone disorders?
Some alopecia, or so it gets
Alopecia is not a bone disorder.
sorry, osteomalacia. Sir, sorry.
तुम alopecia बोल रहे हो?
Sorry, sir.
Okay.
Osteomalacia.
ठीक है. Okay. What else? Aluminium, and dialysis dementia. What else will you expect in long term?
So long term, sir, dementia
वो तो हो गया.
and osteomalacia. These are the long term, sir.
Osteomalacia, neurological complication.
No, not neurological.
We talk about neurological complication. See, understand my predicament. We have a patient on chronic hemodialysis. So the viva will be a little bit of etiology, whatever etiology is, which is always very common. And I want to tell you that etiology will be important in managing this patient further, which we have discussed: diabetes, ADPKD. If you had some congenital things, it may have association with other organs, things like that. So we have gone over it. Now we are talking about chronic complications of dialysis. I think that is the reason why this case was given to you by Anurag, I think. What are the other neurological complications you know of? You should tell us.
So fractures can cause. So fractures can cause.
Mononeuropathies, amyloidosis, ये सब पढ़े हैं ना बच्चे?
हाँ sir, carpal tunnel
Wernicke's
syndrome.
encephalopathy. Then sometimes you may have biotin deficiency causing encephalopathy. That is not so very common, but just remember it. Okay.
Yes, sir.
Okay. What else?
Sir,
Beta 2
carpal
microglobin
tunnels.
deposition will give rise to, yes, carpal tunnel, other
syndrome.
mononeuropathies. Quite right. What are the carbohydrate metabolic complications?
Like hypoglycemia.
Yes. What does
hyperinsulinemia occurs. There is a increased tendency for hypoglycemia in CKD patients, sir.
What else do they have? If you do their lipids, what do you find?
It's more of triglycerides, low LDL,
yes.
but that
VLDL, low LDL.
yes, sir.
Normal.
Low HDL, sir.
Maybe. Yes, quite right. What else?
Some metabolic.
What happens to protein metabolism? That is very important.
Yes, sir.
Let's talk a little bit about protein metabolism.
The protein catabolism, sir, occurs because of the increase in inflammation. So the protein requirement is high in dialysis patients.
How much?
So it is around 1.2 to 1.5 gram per kg per day, sir, in dialysis patients, sir.
In all types of dialysis?
No, sir. PD, PD, we have.
It is different from ISD, MSD, PD, yes. And then prolonged dialysis. Okay. So what is important is what are the other reasons of protein deficit states in these patients?
Decreased appetite, sir.
Catabolism, decreased appetite. What else? This you have to tell me. I can't let you go without telling this reason. It's very important. If your patient is not catabolic, do you think he will remain protein neutral, nitrogen neutral?
Metabolic acidosis.
वो तो है ही है. वो तो तुम अच्छी dialysis दे रहे हो. You have corrected it to a significant extent. Don't you know amino acid loss in dialysis?
Yes.
How much amino acid is lost in a dialysis?
I don't know this exact.
This is very important. This is very, I would not hold anything against you, but this I will hold against you. If you do not know the amount of dialysis, in one dialysis, how much amino acid is lost, beta. This is very important. And what is the difference from CAPD? Then you should also know the amount of amino acid which is lost if you are doing online hemodiafiltration. I'm sure in Gangaram now you're doing more and more of HDF, right? Correct?
Yes, sir. So PD, there is more of albumin loss.
PD chhod do. I'm not, that's why I came back from PD. That is not the topic of discussion. Let's remain on hemodialysis. So you lose about 15 grams of amino acids in one hemodialysis session. What are the factors which govern how much amino acid you will lose in a dialysis? What are those factors? One is the online hemodiafiltration.
Yes, sir.
You will lose more amino acids in online SDF, or you will lose more in hemodialysis.
Sir, the high flux dialyzers are used, sir. I think will lose more in HDF, sir.
Yes. Obviously, you lose more in SDF, nearly 30-40%. You will lose more in SDF, right? And that is the reason you have to upgrade their nutritional content. When you say that the patient is in neutral nitrogen balance, correct?
Hmm.
What do we mean by that? That the patient is in neutral nitrogen balance.
So we are supplementing the loss with.
बाल्टी में 6 दो कितना पानी डालते हो निकलता जाएगा, that is not neutral nitrogen balance. When we say neutral nitrogen balance, what do we mean by that? What are the markers which will tell you what is neutral nitrogen balance, and how will you achieve neutral nitrogen balance? See, you have to understand, this is important because only then and then, I'm sure Gangaram did a good job. That's why he's 10 years old on dialysis. The USRDS data of 2016 was 4-year dialysis outcomes in a country like United States is 65%. So it means that at the end of 4 years in United States, 35% people die. So you can well imagine what's happening in India, right? And this is no old data, 6-year-old data. I don't know what's the new data. How do you prove a patient is in neutral nitrogen balance?
It calculates a urine.
Urine to I need, he doesn't pass urine.
He's
not passing urine. Okay, this is important. You will have to check. What is the molecular weight of urea?
Sir, 60 Dalton, sir.
60. What are the middle molecules you know of which will go out in dialysis?
Sir,
Actually, problem यही है ना, examiner can have flight of and he can go from anywhere to anywhere and there's no stopping him.
PTH,
what are the middle molecular weights?
PTH, beta 2 microglobulin, vitamin B12.
What else? What else?
This cresol, endoxyl.
नहीं ठीक से बताओ. These are important. These are important stuff. This is important.
Sir, endoxyl compounds, cresol, phenol, amines, beta 2 microglobulins, PTH, B12. So these are the middle molecules.
And which are the big molecular compounds?
Albumin, kappa lambda light chains, sir, immunoglobulins. Cytokines, sir, interleukin
TNF
6,
alpha,
TNF alpha, interleukin 6, interleukin 2.
These are the big long. Quite right. Quite right. Interleukin 6, hepcidin, these are the long molecular weight compounds. Okay. Very good. Have you heard of expanded hemodialysis? Have you heard of expanded hemodialysis?
Yes, sir.
What is that?
Sir, we can use, sir. I'm not sure.
These are the newer things. You must be
Yes,
very
sir.
sure of this. Hai na? You should be very sure of this.
So the other filters like which have come, sir, I think, sir, it's a middle cutoff and high cutoff dialysis.
All of the postgraduates who are listening have to be aware of all that. Okay, you have to be aware of all these things.
The middle cutoff dialyzer, the high cutoff dialyzer, sir, all these are, sir, extended hemodialysis, sir.
How can we classify dialyzers? Any classification you are aware of?
Yes, sir. We can classify according to the flux, according to the efficiency, sir. It can be low flux,
Like?
low flux, high flux, sir. It can be low efficiency or high efficient dialyzer, sir. It can be then.
There is a good Japanese classification based on beta 2 microglobin clearance.
Yes, sir. So recently
you can depend upon that also, hai na? How much beta 2 microglobin you are removing.
Yes,
and if you are removing lot of beta 2 microglobin, they will not have long-term complications, arthritic complications, neurological complications, polyneuropathies, things like that. So it's also based upon stage 1 to 5, dependent upon the beta 2 microglobin clearance, flux, as you said very correctly, things like that. Okay.
Yes, sir. So it is the recent ones that paper they are told it is replacing beta 2 microglobulin is replacing the flux type. So they are more of it is depending on beta 2 clearance. the low beta 2 clearance and high beta 2 clearance.
What are the importance of middle molecules and large molecules?
So middle molecules are mostly it is responsible for inflammation, amyloidosis, sir. Like the beta 2 microglobulin is a prototype for middle molecule. So they increase the inflammation in the body, they increase the cardiovascular morbidity, mortality, they increase amyloidosis.
Cachexia, malnutrition, right?
Yes, sir.
Like TNF, etc. What else?
Yes, sir. HDF. So that's why we prefer HDF over HD.
And then cardiovascular disease also.
Yes.
Erythropoietin resistance, secondary immune deficiency. All these things are very common. Okay. Is there any difference in membranes? How many membranes you know of?
Sir,
Dialysis membranes.
Initially, sir, they were cellulose membrane, which were bioincompatible. Later,
why they were bioincompatible?
So because they used to cause more of complement activation, more cytokine reaction. The cellulose per se, the adsorb, like it was
they had a hydroxyl
compound. Yes.
It is replaced. Then we bound the hydroxyl. When I was a postgraduate, we had only cellulose acetate membranes. Whose company there was a name also, which I have now forgotten. Okay, what other?
So this
because of the hydroxyl molecule, there were problems.
It is now, it can be replaced by acetate. So we have semi-synthetic membranes like cellulose acetate, cellulose triacetate. And the synthetic membranes are, sir, polysulfone, PMMA, polymethyl, PMMA and polyacryl nitrile, sir, PAN.
So what are the advantages of these newer membranes and what are the disadvantages?
So the advantages are, sir, they are more biocompatible. So low complement activation, low dialyzer reactions, sir. And so these are the main advantages. Disadvantage, sir, as such a PAN, if used with ACE inhibitors, sir, it can cause a reaction.
One or two membranes had that disadvantage. I think another disadvantage is perhaps a little bit more amino acid loss. Otherwise, they are certainly less inflammatory. Okay.
Yes.
What are the dermatological complications that you know in dialysis patients?
Pruritus, sir, xerosis, sir, dryness of the skin, that is the most common, sir. And sir, then we have.
Why does pruritus occur? It's such a nuisance in dialysis. What are the reasons for pruritus?
Sir, pruritus, sir, inadequate dialysis is one of the inadequate dialysis, high phosphorus, high PTH, sir. Then, sir, we have actually two hypotheses. We have immunological hypothesis and opioid hypothesis. In immunological, because of the systemic inflammation, there is itching and not per se the skin inflammation, local inflammation.
Right.
And the opioid hypothesis says an imbalance between the kappa and mu receptors. The increased mu receptors and decreased kappa receptors cause, sir, pruritus, sir. So that's why, sir, we have different agents like that can act on this.
Like.
Sir, we have diflucalphalin, which was kappa receptor agonist. We have narferefon, which is kappa receptor agonist. Naltrexone, antihistaminic, gabapentin, pregabalin, sir, all this can be used, sir.
What other dermatological complications, you know?
Sir, we have, sir, if it is associated with diabetes, sir, we can see acanthosis nigricans, we can see the diabetic.
See, that is a complication of diabetes, not of hemodialysis. Although you can mention it if you want. What are the dermatological complications of long-term dialysis?
The black spots over the shin.
Every day.
Black spots over the shin. Diabetic spot. Sorry.
Diabetic spots.
No.
What other complications you know of cutaneous manifestations of ESRD patients? One is pruritus. Xerosis is very common. You should be able to tell us.
Yes,
then pigmentation. Have you not seen pigmentation,
yes,
especially at joints? Patients say, "Doctor, ye mere kala kyun pad raha hai?" Why do you think that occurs?
Sir,
why does they get pigmentation?
I'm not sure, but because of increased melanin depositions.
Very good. melanotropic hormone collection causes it. What else? अभी तो दो तीन very important. I think after that I will give to Anurag. नहीं तो भाग जाएगा वो. क्या 7 बज गया? ओहो. I think we are falling.
मैं तो खुद ही सुन रहा हूँ आपके
अरे
क्वेश्चन.
तू बेकार बात मत करा कर, बदमाशी करता.
नहीं सर, मैं तो ले चुका था इसकी क्लास. आपने और सारा कवर कर दिया है इसको बिल्कुल.
नहीं अरे बच्चे आजकल बहुत ज्यादा है यार, हमें नहीं आता था इतना when we were doing DM. I have no. नहीं हम लोग तो ऐसे पास हो गए गलती से. What else? Tell me.
लगभग तो सर कवर हो गया है, मतलब
Okay.
इसका all we have covered actually in this. आपने सारा पूछ लिया सर अच्छे से, तो ना ये इस पे इसको सारा न्यू ओल्ड सब कवर हो गया सर.
Another thing I want to tell you, in which I have seen in my experience, friends, which sometimes we don't do. If your patient's anemia is not improving, you should be very careful. You should look beyond kidneys. Once in a while, you will find a salt sitting in large intestine or somewhere, and you may move heaven and earth, the anemia will not improve. And another thing that I have seen is from my experience, and it's also written in books, it's not my original experience, that in end-stage dialysis patients, sometimes maybe once in a year, we should do the ultrasound of their kidneys. Sometimes they get RCC sitting there, especially if they have cysts. They have malignancies, which we miss, and then the metastasize is always a problem. Okay. So these are some of the other immunological long-term complications which you have to see. What else can you think of? Anurag, you take over now. Close it or whatever you want to say.
So Gaurav, tell me the diagnosis, final diagnosis. No, sir has also grilled you on some points. Tell me the final diagnosis.
My diagnosis is chronic kidney disease, stage 5D on maintenance hemodialysis. Basic disease, sir, first differential hypertensive nephrosclerosis, second differential, sir, query chronic CG, and secondary to, sir, IgA nephropathy or FSGS with hypothyroidism, with essential hypertension, with intradialytic hypotension, with history of CRBSI, COVID, recovered, sir.
Intradialytic hypotension.
Hypotension, sir. Frequent, sir, हो रहा है उसको अभी last 3 months से.
What's the point in favor of making a diagnosis of benign nephrosclerosis first?
Sir, he had hypertension before the history of kidney disease. Secondly, it was persistently, sir, elevated blood pressure, and he was non-compliant to it.
How long the blood pressure was prior to?
Sir, he was detected in 2010, but we don't know, sir, whether it was present before 2010 because he did not measure it. He
what
was
is
not
the
on.
natural history of the hypertensive nephrosclerosis?
Sir, most of the patients, sir, they are stage 1 or stage 2 CKD, sir, and only 5% progress to ESKD. That too after 15-20 years, and in uncontrolled hypertension, sir, BP more than 160, sir.
So whether he was on regular medicines?
He was not taking, sir, any antihypertensive medications. He did not. He said he was not having any symptoms, so he did not take any medication, sir.
Okay, he was not taking any. But you are anticipating that he must be hypertensive prior to 2010 also.
Yes, sir. Yes, sir.
Okay. What's the age of the patient?
Sir, 62 years, sir.
Why are suspecting IgA nephropathy in a patient of 62 years and FSGS in a 62-year age patient?
Sir, IgA nephropathy, sir, epidemiologically it is commonest cause of CKD, sir, and there was no history as such suggesting.
Commonest cause of CKD doesn't mean it will fit in each and every CKD.
There was no history.
IgA nephropathy is which decade it is most common?
Sir, it is a disease of middle age, sir. So mostly, sir, 2nd to 4th decade, sir.
2nd to 3rd decade. So at the age of 50 years, you are suspecting that he is having IgA nephropathy which progressed over a period of 10 years. And which
yes, maybe, sir, he had at 40 age, which progressed at. He was
without any symptom, without any intermittent.
Sir, hypertension, yes, sir. He did not have any symptoms. Yes.
which FSGS will progress without swelling over lower limbs and without frothy urine. So you are making a diagnosis, then the examiner will ask you point in favor and point against. When you're making a chronic glomerular disease diagnosis, you are not fulfilling any point in favor.
So maybe, sir, IgA nephropathy was diagnosed at 40 years and it progressed.
IgA nephropathy diagnosed at 40 years and now at 60 years is dialysis dependent. How without symptoms, which IgA nephropathy will progress like this?
He just had hypertension, sir. Nothing.
So we have seen patients when we did a biopsy, some patients who are presenting as advanced renal failure. In Indian settings, they have more of chronicity, but you can stick with one diagnosis also. It is not always key. You are see at 60 years. Another thing is CKD-U, you can say.
And another thing we forget is somehow is the atherosclerotic disease. It's not so uncommon. Ischemic renal disease. Don't forget it. It's not so uncommon. It'll come surreptitiously.
Ischemic renal disease could be there.
This patient, I asked, sir, but he did not have any cardiac history, not peripheral vascular disease. No atherosclerotic disease per se was present. So
that may not be there. That may or may not be there.
Actually, it should be first, okay, you're going with hypertensive nephrosclerosis, then atherosclerotic renal disease, then it should be, you should not see at the age of 60 years, you are making glomerular disease with no prior history. That is the problem.
Yes. Yes, absolutely.
So, the thing is, I think, sir, he presented well.
He presented well. Absolutely. My congratulations.
Yeah.
You've done a good job. There's no doubt about it. And I would say all the listeners should be very, very thorough in hemodialysis. Hemodialysis is the bread and butter of all nephrologists, and we ignore it the most.
Yes,
we are in love with transplant, but your bread and butter always will remain hemodialysis. Okay, so there's so much to learn and ask in hemodialysis, malnutrition, inflammation. You take any aspect and you can talk for hours on that. The literature is full of it. So I think we had a good evening. And Anurag, I think so we close here?
Yes, sir, definitely. Have a good day, sir. Good night, sir.
Anurag. Thank you.
Thank you, sir. Thank you very much.
Okay.
Thank you, sir.
Okay. Thank you, Gaurav.
Thank you, sir.